Okay. So, panel number one. All right, I got one down. I have 3 to go, I think. Yeah, so Ginny's nodding. It's a little bit of a busy day for me. So this panel, our first panel, what we wanted to do is kind of start kind of at the beginning, right? So we wanted to take some time to talk about, thank you, kind of provide a CPAP overview and how the CPAP, and I should actually define, CPAP is a charitable patient assistance program. So that's the acronym CPAP. And how we are different from manufacturer programs. With me today, I have Michelle McCourt, Executive Director from Cancer Care Copayment Foundation. And I have Fran Costello, President with Patient Advocate Foundation. So thank you so much for joining me. Okay. So the challenge that we're kind of looking to address with this particular panel is that there are many manufacturer patient assistance programs, or PAPs, and charitable patient assistance programs, or CPAPs, working to close the cost gap between treatment plan and actual treatment, that it can be very confusing for patients and hard to keep straight for advocates and providers. So the objective is we wanted to kind of talk through the general differences between manufacturer programs and CPAPs, what is the same, what is different, how they operate differently, and talk through some scenarios when one patient may access multiple programs, offer some clarity around the differences, and give advocates some tools and manufacturers food for thought. So the first slide I want to show, ooh, look at that. So the patient experience can involve a lot, and this is from Cancer Care, so I'm going to actually have Michelle kind of talk through this flow.
So this is actually 3 Cancer Care clients, and the slide illustrates their particular journeys, specifically to get financial assistance. And as you can see, it's very colorful. It looks pretty, but what it really illustrates is that there is a lot going on all at one time, a lot of different moving parts. And this is really an opportunity for patient advocates or navigators to help patients step in and help them navigate through all of the different programs and processes that are out there and just really kind of understand what they're dealing with.
Great. Thank you. And the 2 most likely tools for advocates directly related to treatment manufacturer assistance programs and CPAPs. So really, those are kind of the big tools, right? When there's a cost problem, when the patient is unable to afford the treatment that their physician has prescribed, kind of the big tools are the manufacturer programs and the CPAPs. So we wanted to really clearly define what we're going to be talking about today. So manufacturer patient assistance programs, we'll go a little bit more in depth about this. They're really programs that are designed and funded by manufacturers for their specific products. The offering and the eligibility can vary by the manufacturer, and programs for products manufactured by the same manufacturer may also vary in terms of offerings and eligibility. So you could have one manufacturer who has multiple products, but each of those programs is a little bit different from the next. They can offer a variety of assistance in a variety of combinations. They can do insurance coverage investigation, prior authorization assistance, copay assistance, and free product. And on the flip side of that is the charitable patient assistance side. These are national charities, independent from their donors, which tend to be the pharmaceutical manufacturers. They have consistent criteria fund to fund. So within each CPAP, the funds are managed pretty much the same. The financial assistance can actually cover a wide range of areas. The big difference is that we can actually help Medicare patients, and we can offer additional support or work with strategic partners or alliance nonprofits for other areas like education, community support, and other things. So let's talk through some of the differences. So the question 1, and I'm going to have Fran kind of walk through this, is what is the biggest differences between manufacturer programs and CPAPs?
Thank you, Krista. I think there's often a lot of confusion. And I know I've sat in this role for 23 years since before we had a copay program, and I continually get asked the same kind of questions about, well, why don't you do this or that XYZ manufacturer does or doesn't do? Why can't you do it this way? And it's because we're really different. And I see Erin shaking her head, and we share counsel, so good to see you, Erin. So manufacturer programs, as Krista said, they are run, set up by, and owned by manufacturers. They are typically either run by a foundation in-house or they hire somebody, a third-party administrator or hub, to administer those benefits. They typically only support commercially insured patients. They also have a kind of third rail, if you will, which is free drug. We mentioned that earlier. That's also administered by the manufacturers for uninsured patients, and in a rare case, Medicare patient if they're uninsured for their product, but I won't get into all that. So that's kind of the critical difference, right? They get to control it. They get to design the eligibility criteria, the income criteria. Typically, there aren't any, or they're really high. You've probably noticed charities are not that way, and that's by design from the OIG. They really say, like, hey, you're here to help the neediest of the needy. You're not here to help people at 1,000% of FPL. Not saying they don't need help, but that's not your role. So thinking there's also some restrictions that we have that they don't have. So manufacturer programs, they can promote it. You see their ads on TV, you hear them on the radio, you see them in the doctor's office. Their sales team can go in and, detail those doctors about, hey, if you put a person on our product, this is the program that you need to get them enrolled in. We cannot do that, nor can they do that. If they donate to our program, the reason you don't see our donors listed is because we're not allowed to. And I'll tell you what, Krista and I've been doing this a long time. Talk about raising money and saying, and by the way, I can't tell anybody that you're giving me this money, was a trick back in the day. And it still is in some ways. So we're really restricted on not being able to talk about those donors. And it really is because charitable patient assistance is governed by what's called an OIG opinion. It's an opinion issued from the Office of Inspector General out of the Department of HHS that we seek as charities, informing them of our plan. So what does our program look like? Who's it going to serve? How is it going to operate? And they opine on it. They give us an opinion back and say, you can run it in this way. And if you do run it in exactly this way, you will be protected from the kind of penalties under the anti-kickback statutes and the civil monetary penalty laws. So think doctors being influenced to prescribe certain medicines. That's what they're trying to avoid. They don't want to, sales rep going in a doctor's office and saying, hey, we gave money to PAF or Cancer Care or HealthWell. Write a bunch of scripts and send your patients over there and they could pay their copays, and they're all on Medicare. So that is a key difference between us and the manufacturers. And then lastly, we tend to be more generous, I would say, and broad in what we support. We don't care what patients take at all. It doesn't matter what drug they're on. In fact, in my program, we cover supportive meds and all of the funds. In addition to the therapeutic products, manufacturers don't. And that's okay, right? It's their program. They're covering their products. So if you have a patient that has other needs, they're not going to be met just by going to a manufacturer program. So that's really, there's lots of other kind of nuanced differences, but I think those are probably the large ones. The last piece is reporting. You'll never see a report come out of one of us charities that has anything to do with the products, the payer mix, how many patients are on a certain product. They can do that all day long in their own programs. They get that data. And they know exactly how many people got enrolled and the value of all of the assistance they're providing because they report it. We cannot do that. We can't even report that to them. Again, that's kind of tricky. Like there's a limited amount of data that we can report. So I hope that kind of grounds us in the difference between the two, because there is a lot of confusion. In the question that was asked earlier about why can't you all go through one portal? Well, these are some of the reasons why we can never kind of commingle even ourselves sometimes, but certainly not with manufacturers, even though that would provide a better patient experience.
Great. All right. Okay, so I'm going to move on to the second question. So what role does insurance play in our different programs? Michelle or Fran?
So as far as insurance, I mean, in our funds, patients have to have insurance that's covering a portion of their medication in order to be eligible. The majority of our funds are limited to patients that are on, that are federally insured, so Medicare, TRICARE. And so the drug does need to be covered. We are the second payer. So that's they have to have insurance to be a part of a copay assistance program.
Right.
I think the one thing I'll add to that, ours is similar. That's pretty uniform across all of the charities. It's a requirement. We are a co-payment organization, so having a copay, co-insurance, or deductible is kind of where we fit in. The one exception, it's not an exception, but the one kind of nuance is for the Medicare population. When they're in the donut hole or the coverage gap, we can pay 100% of their cost because that's their cost share during that period. But the drug itself still has to be covered. So it runs through insurance. You've seen it. It's covered it's covered by their plan, but the plan's not paying because they're in the coverage gap. That's a plan design issue. So we can actually fill that gap for them. And if you look back on the origins of charitable copay assistance programs, the gap, the donut hole is the reason we exist.
Yeah, and as a nonprofit, what we pay counts towards their true out-of-pocket cost to get them through that donut hole and into the catastrophic.
Great. All right. And question 3, there is a lot of focus and concerns around first come, first served. Can you explain why that is?
Yeah, I'll take that one. And anybody who's in here that's in technology, listen up. I have been asked no less than 25 times today. I'm just kidding, but over the past year, seriously, by health IT companies, can you integrate with us? Can you integrate with us? It'll make our customers' lives so much easier. They want to just apply right through their EHR. Well, guess what? Not everybody uses the same EHR. So if I integrate with one of you, I've now given preference to those customers. And I've given preference to those patients. And the OIG has been super explicit with all of us that these programs must be first come, first serve, no exception. So that is, it's a hard and fast rule that we all have to live by. I know it's frustrating, especially those of you in the clinic that like a fund opens and then it closes and you're like mid-application and the fund closes and you call and you're like, can you please get my patient in? And we have to say no. Because how would we do that compliantly?
Right.
So that's, I think that's, it tracks back to our OIG opinion, and it is very different again from those manufacturer programs.
And I'll just add that we're also, we can't do batch enrollments. So even if we're not integrating with an EHR, we can't accept batch enrollments. So a facility can't say, I've got, just 10 people. I have 10 people on the list and I can send over all the applications at once. They have to be submitted one by one because as that entity is submitting, there's other entities and individual patients all submitting, and it basically comes into the queue as a stack, and you work through the first one because they're first served. So yeah.
Sorry, Michelle, were you gonna?
That's okay. No, it is a challenge, and sometimes it's a challenge for even getting your staff to understand because they're on the front lines and they've got somebody on the phone and says, well, I called and I've been on hold for this long. There are many different ways that patients can apply. Some people do still calling on the phone is their only way, and we do know that the funds go quickly. So it's very heartbreaking sometimes when we know somebody's been waiting. If we had an infinite amount of money, that would be wonderful, but that's just not the way it is.
Great. Okay, next question. As nonprofit entities, CPAPs are able to offer assistance that goes beyond the products. What are some examples of that going beyond that you guys have?
Yeah, so in our program, we actually support health insurance premiums for any and all insured. So that's Medicare, supplements, Part B premiums, as well as commercial premiums if we have a commercial patient, marketplace premiums. That has been very beneficial for a lot of patients, because that's their greatest need or greatest expense in a month that sometimes they have a hard time coming up with. We also can pay for office visit charges on the day of treatment. So if you go for an infusion or an injection, we can actually pay for that office visit charge. That really came out of, we went back to the OIG and asked for that because of HMO plans that often that's all the patient owes is a copay for the office visit. And so we weren't, in the beginning, we couldn't help them at all because there was no drug charge. So we also pay for the administration charges related to those medications. So professional fees related to giving the administration of those medications. And then, of course, outside of that, you touched on this earlier, there's a lot of ancillary needs that patients have that are really drivers for their compliance with their treatment. And that's everything from transportation, which you probably heard about a lot, but more importantly, I'd say in the past few years, like very basic things like food and nutrition, rent and mortgage and utilities. So we all, I think, have some form of other financial assistance programs that are kind of part of what we do for financial assistance, not part of the copay award necessarily, but an additional way that we can help patients with some of those non-medical needs that we know if they're not addressed, the copay grant kind of sits unused because they're really not getting to they're really not getting to care.
I would just add, so at Cancer Care, we have two parts of Cancer Care. So there's Cancer Care, which has been around since 1944, and then we have our Copayment Assistance Foundation. So patients that come to our Copay Foundation have direct access to Cancer Care, and through those programs, we do offer limited financial assistance for transportation or supportive medications. And then we also provide free psychosocial support through our oncology social workers, which we've been doing for many, many years. So, and then we also have educational programs. So, we try and address all of the needs of those patients.
And I'd like to add that tomorrow on the main stage, I think midday, there's going in the morning. Okay, I'm checking for cues. So in the morning, there's going to be a main stage event where the question is going to be, as advocates, what else do you need help with for your patients? Like what pockets of costs are really being, causing some devastation and impacting their ability to kind of not afford other things. So I encourage you to think through and write up a nice list and then raise your hand tomorrow on the main stage. And so we'd love to hear your feedback on that, because there's, I like to think of sometimes what we do is like, it's like a balloon, right? So if you can squeeze one side, then another side is going to be taken care of. So if we, it's kind of, not to spoiler alert, creative budgeting, right, with patients. I don't need help with my copay, but I really need help with my food because I can't afford my food. Well, but I can get you a copay. I can get you copay assistance. So let's get that. And then you use what you were going to use over there for your food. So being a little bit creative that way. I don't think there's, we can't come up with enough programs to take care of every single patient for every single facet of what their needs are. But we'd love the feedback, and we're always looking for new ways to just kind of help patients kind of where they are and meet them there. So thank you for that. Question 5, can patients be enrolled in a manufacturer program and a CPAP program?
So yes. So patients can be enrolled in a manufacturer's program. Maybe they're getting the coupon or something through them, and then they could probably be getting a premium assistance from HealthWell or PAF. But we tend to not want them to get assistance from copay foundations for the same drug at the same time. That's just, kind of funds are limited, and we want to be able to help as many patients as we can.
Yeah, not a lot to add there. I mean, there's no restrictions. There's honestly no way to police that. I'll be completely candid. Like we mentioned earlier, we can't share data, nor would we. So we do know there probably are patients that are in all of our programs for various reasons, some of which we've already talked about. Like we all kind of cover some of the same things, and then there's some other things that maybe I cover or Krista's program covers. But I do think the manufacturer programs play an important role in augmenting copay support for certain patients whenever that makes sense. So as an advocate, I have a team of case managers, much kind of like cancer care, where our copay program started in '04, but we actually were founded back in 1996, providing case management services, not giving away money, and learn very quickly of this need. And our case managers will tap into any and all of these resources. So I would encourage you not to just go where it's easy, right? Like, don't hit the easy button and go get money and say, oh, I'm done. Because frequently there are other resources or other needs that patients have that resources like the manufacturer programs might be the right fit for.
So we wanted to share too, for our advocate colleagues, the best way to kind of track down manufacturer patient assistance programs. So we came up with 2. So again, I mentioned Needy Meds before. Rich is here. He'll be down in our exhibit hall, and he's on one of my panels later. But this website is fairly robust. You enter the product name, and it'll come up with if there's a manufacturer program, if there's a foundation that might have a fund that's open, and then the contact information as well. And then there's also the medicine assistance tool, which is MAT. It's through pharma. It's supported by pharma. It doesn't have, if it's not a member pharmaceutical company, it's not listed, I believe. So it's not quite as robust. Again, Needy Meds is an .org. So it's a nonprofit, and it's focused on just getting the information into the hands of the advocates, and membership doesn't matter for them. But we wanted to share that. And then we also wanted to share kind of the list of the CPAP community. And it was brought to my attention today that Leukemia and Lymphoma Society also offers assistance for certain cancers. So very similar setup to all of the other CPAPs in the space. But we wanted to make sure to get that information out there. I know that there's a pretty universal commitment to having transparency on the application process and the funds that are available, what the status is, kind of what you get if you apply. So the websites are fairly robust, but we do work to make them as friendly as possible for our users. And then the last thing that I had, did you guys have anything else that you wanted to add before?
I just want to highlight Needy Meds. I mean, they're awesome if you've never used them. I was in a session yesterday with Rich, and he said they have 40,000 resources in there. That's pretty steep. So I know our case managers use that tool a lot. I would encourage you to. It's completely free, and it's been around forever. So it's pretty tried and true.
Your slide with our website. So that's actually cancercare.org. And then we actually have another one, cancercarecopay.org, is specific for the Copay Foundation.
Yeah, same with us. Our Patient Advocate Foundation website. You can find our copay program by going to our main website, but we do have a website for copay. It's copays.org.
Great. And then I think, so one of the things that we've been talking about, and we've had conversations around closing the loop. So as advocates, it's a lot of work to connect your patients from, with the different programs. And then you kind of say, well, I got this for you. Here it is. Go. I got to move on to the next patient so I can help them, kind of connect them with some assistance. And there's sometimes things that are lost in translation because the patients, again, we struggle, right, as an industry, understanding the differences between all the manufacturer programs and the CPAPs. It's only worse for the patients, right? So they get letters in the mail and they're like, how did I get this? I have no idea who these people are, what they did. I have no idea. Are they legit? Are they whatever? So we actually created a video to help kind of close the loop. So this is a video that we've created. It is for patients. It is not branded, and it will be available through our website. You can go and download it. I'm looking at my team. We're going to allow it to be downloaded. Anybody can use it. And it's just an easy way to kind of say there's manufacturer programs, and then there's CPAPs, and they're legitimate, and they're vetted, and all of those good things.
Hi, I'm Melissa, a patient advocate. Have you ever been surprised by the cost of your medication? Often, patients discover their insurance pays less than they thought when filling their prescriptions. I work with patients who have difficulties affording their out-of-pocket costs by helping them find funds to cover what the insurance doesn't pay. For patients with private health insurance, You may qualify for funding through the manufacturer's drug assistance program to help pay for what you owe after the insurance pays its portion. You should take advantage of these programs if available. Speak with your healthcare provider or pharmacist to learn more. If you're not eligible for a manufacturer's program, a charitable patient assistance program, also known as a CPAP, may be a good option for you. CPAPs are national nonprofit organizations that provide grants to help with your cost shares, like copays and deductibles, after your insurance is paid. CPAPs help patients with all types of health insurance, including private insurance, Medicare, Medicaid, and TRICARE. CPAPs are real entities. They are regulated national nonprofits and are rated annually by leading charity watchdog groups. You can check some of their ratings on these websites. These charitable programs are free and there is no cost to apply. Applying is easy. In most cases, you can find out about your grant approval in a few minutes and use it immediately. You are also not required to repay the grant. If you cannot afford your cost shares after insurance pays, you may be eligible for financial assistance through one of these charities. Eligibility is based on your insurance, income, and medical diagnosis. Here are CPAP organizations that offer financial assistance. Visit their websites or call to learn more.
So again, this will be available on HealthWell's website and used for anybody. I really encourage people to just kind of take advantage. It helps kind of explain the process for the patients without kind of tying you down, right? Because you can say, open it up on your phone, or here's a laptop or something to look at it. So with that, I wanted to, any final comments, and we'll open it up to Q&A to the audience. Okay. Q&A? Yes, in the back.
Or do you as an advocate really have to go in and try to do it for your client?
Yeah, so I can speak for our program. We have hospital billing offices, financial counselors, as well as those in practices using our program regularly. We certainly do outreach to all kinds of different healthcare stakeholders to make sure they're aware of our program. Back in 2004, when we first got into this, it was a really tough road to get doctors to believe that we were going to give them money, give patients money, and it was real and legit, and it wasn't going to disappear on them. But over time, we've kind of reached critical mass with all of us helping so many hundreds of thousands of patients that we do see good use. I will say we have some funds that are not in the cancer space. About 50% of our funds are non-cancer, and there's less organization from an advocacy and a support perspective in other diseases. I think I can say that pretty broadly, particularly in the rare disease community, because there's so many different diseases. And I see a lot of that in the cardiac community where there's use, but there's still a lot of work to do from an advocacy and education perspective on all kinds of resources, not just copay, because patients are often left to kind of figure it out themselves because there's just not quite the level of sophisticated, organized support that you see in cancer or maybe HIV.
And I think too, the manufacturers actually can refer people, entities, individuals, patients over to the charitable programs. They just can't say, we donate here. So I know they have funding. They have to be careful about the wording. And typically, kind of the safe approach that many manufacturers will do is they'll say, here's 3 foundations that might be able to help you. They all have this fund, so you'll need, but I don't know which ones are open, and here's their website and their phone number, and then they kind of step back. Again, that's kind of some of the rules and regulations, that the nuancy stuff that we have to follow to make sure we stay, compliant within our operations. So, but I agree with Fran that it's definitely changed. It was, for a long time, it was rider offices and pharmacies. And now it's getting into the hospital and clinic settings as well. Yes.
Are there ever funds that go underutilized, assuming you want to get to zero? What would be the
common conditions? Is it just the super rare stuff that doesn't get fully spent in a particular calendar year? Or do you all, if you're able to say, legally, do y'all carry over funds from year to year? Or is that just, you go back to zero each year? It's kind of,
You guys, I'll comment on that.
Yeah,
We're all a little nuancy, so.
have to
We
be
deal-
careful how I phrase it, I guess.
we deal primarily with cancer because we're cancer care, but we do have a few funds that towards the end of the year that we actually have money left over to carry over to the next year and have stayed open consistently throughout the year. But that's not the norm, unfortunately.
Yeah, I agree. There's more need than money across almost every disease state. We absolutely work a donation until it's gone, however long that takes, whether it's a year or 2 years or whatever it is, or 2 months. So there's really no time limit on that. When you accept a donation, the agreement is you're going to give it all away. So that's what we do. There are some, the funds that we have had that have kind of been sustained longer. I wouldn't call them underutilized. They're just a little bit slower use because the population is smaller and the disease is more rare. So the need is just is different than, a breast cancer or RA or something where there's hundreds of thousands of people looking for that kind of help.
Yeah. And I'll say from HealthWell's perspective, we also roll over, so it doesn't reset. As new donations come in, we release it into the fund, and our job is to program it out as fast and as efficiently as possible. I know that we actually, my communications and marketing team works very closely with the operations and development team to really promote kind of our, and again, I wouldn't say that they're underutilized. They're just, the money's just not moving out as fast as we believe it could. So we do kind of promote those on digital media and do different campaigns there. And then, the flip side is, quite honestly, there's a different perspective. There's a different approach. Donors have different approaches to how they support different funds. Some of them, they make an internal decision that no matter what it takes, we're going to keep that fund open for this long, and they just do it. And others, it's more of a, they have to do what they can, and they do it when they can, and they see how far it goes. So it's kind of a combination of different things.
Yeah, I would just add too that we're constantly looking at the utilization within the funds to make sure that the funds are being used.
Right.
So there is a period of time when the funds, the patient isn't using it for whatever reason. We do reach out and let them know, hey, we've given you a grant. We need you to, we're not getting billed for it. Sometimes that's when we might find out they're getting help from another foundation. And then that money will go back into the disease fund and become available again for new patients. So it's a process, but eventually sometimes we get what we call credits into that fund, which is enough to reopen it or keep it going.
Right.
I have a question. On the industry side, we're seeing more challenges with alternative funding programs and copay accumulators, and you're starting to see industry step back from PAP programs. Mm-hmm. Are you seeing any of those impacts? And if not, what do you think is insulating you from that trend?
Yeah, so Krista mentioned this earlier, the alternative funding plan's super concerning, honestly, from a patient perspective, because I think there's zero transparency about the existence of that plan design when it comes to the consumer. From a charitable assistance perspective, we are a little insulated because there has to be a claim. Even if it's as I mentioned, like a claim where we're paying 100% because that's what the patient owes, there has to be a claim that, and therefore for a covered product. So if the product's off formulary, it's just not covered at all because they've carved it off their formulary, they're not going to be able to submit that they should not be able to submit that to our programs for any sort of payment. I do hear there's a little bit of shenanigans going on out there where they're kind of force billing some things and using some codes making it look like it's 100% patient responsibility and covered. So we're kind of starting to kind of dig into that a little bit because that's not okay. We should not be that backstop for an employer who's chosen a plan like that. That's not our jobs. As far as the accumulators and the maximizers, That is 100% affecting, I think, probably all of us. When they first started, I want to say 5 or 6 years ago with more prevalence, we started seeing in our case management group first with patients calling them saying like, oh my God, I've been on an RA drug on a coupon for 5 years and I still have my coupon and I just went and filled and it's like $2,000. What in the heck's going on? And they didn't know what was going on. And in those instances, we can fill that gap. As we talked about, we can do patient reimbursements and help. I'm not convinced. I don't know if the manufacturers shifting back is equal to, or are they making that up in donations to us? I'm not sure. I don't think so. So we're kind of interested to see how that plays out over time as far as where are the resources? Are they just going away or are they being moved?
And I'll add, from HealthWell's perspective, the majority of our patients are Medicare. And as far as I know, the accumulators and maximizers, they shouldn't impact Medicare patients because they don't qualify for copay programs typically through the manufacturer. On the accumulator side, that technically should not be part of any Medicare plan, although I heard like a small rumbling that there was 1 or 2 situations where they thought it was a Medicare Part C plan that had some kind of AFB attached to it. But I haven't heard follow up on that. I don't know, Alan, did you ever hear back on that? No. So, so hopefully it's not, but that's one area that at least HealthWell is a little insulated from that. I do think it's really important to continue offering the direct to patient reimbursement, because if we can make that a timely turnaround, that's one way, because then what the insurance sees when they run that claim is that the patient paid with their credit card, with their check, with their cash, and then they can get reimbursement. I think it's also very interesting. I mean, there's, because of the accumulators and maximizers, literally an entire industry has popped up to try and figure out how to work around that with a debit card. I've had multiple banks come up and say, we're working on this. We think we have a plan. It's like, you have no idea how complicated this is, because they can lock it. There's ways to lock down different cards and debit cards. But if you lock it down to a pharmacy, there's other stuff that typically that pharmacy is selling. So how do you manage through that? Is it just a risk that you take? So there's ideas on how to work around them, but it is really challenging. And I think it would be, it's unfortunate that manufacturers have to react because they're kind of fighting fire with fire. The problem is it's the patient caught in the middle. And we've seen that so many times with all of this, back and forth between all the different players in the space, that it's really the patients who pay the price, literally and figuratively, and it's the advocates that have to help them through that process. So I think, again, in my first kind of opening remarks, we have to keep talking about these things. We have to keep asking questions. And we have to keep saying, this is a problem. Let's come up with a solution. Because if we're all just kind of figuring it out on our own, it's not going to get fixed at a grander level.
Yeah, I would just add, like, the alternate funding programs right now, to my understanding, are mainly affecting, people with ERISA programs or ERISA insurance, the self-insured, right? The teachers, unions, and things of that nature. We're not seeing anything like that currently because, again, we also deal, the majority of our funds are Medicare, but we're prepared, and through Cancer Care, actually, we have we are spearheading a task force on the Cancer Care side. So, we're learning about it. We're trying to understand how it's going to affect patients. There's a lot of legal things going on, bringing it to the attention of the government. I think there's some appeals and things going on to, is it discrimination? I mean, because it really kind of is, right? If you're discriminating against your employers who need these chronic medications, then aren't you discriminating on, by disease, which should violate yes. Say it again.
The ADA.
The ADA, thank you. So yeah, so there's a lot going on. There's a lot of people looking at it. I believe in our slides through Cancer Care, we refer to those programs as, wolf in sheep's clothing, because they come out as these heroes. They're going to try and identify all these great programs, but these people are paying premiums for their insurance. They're not able to access what they need when they need it. So there's a lot. I think that they're being a little overzealous. I
They're
think
going down.
Yeah, I think so.
If we have anything to say about it, they're going down.
We are patient advocates, right?
That's right. That's right. Yes.
One of the questions, I was making rounds yesterday talking to people, and one of the most frequent questions that I got was, how do the foundations determine how much money to give to each patient? Because we seem to run out of money very quickly. The minute the fund is open, a few minutes later it's closed. And a lot of people have the feeling that we help people for a very short period. We try to help more people for a short period of time. And it's counterintuitive to us who are nurses, who have been patient advocates in facilities, to help somebody, especially with drug, where you get drugs for 2 months. What is it doing for the patient? It really isn't helping the patient that much for that period of time. It might be, but they're not getting the extended care that they need. So the question in a lot of people's minds, and if you all can talk about this, is how do you determine how much to distribute to each patient? And do you do it for the long term, or how does that happen? I know how it happens.
I think we can all answer a little bit differently because we're nuanced again in different programs. So
So we try and look at the utilization of the fund. And when a patient is approved, we give them an initial grant amount. So for most of our funds, it's like $4,000 or between $4,000 and $6,000. That's the initial grant amount. And then each fund does have a maximum cap per year. So we try and make that initial grant amount high enough that the majority of patients are going to get what they need for the full 12 months. And but not too low, so that we don't, we need to account for that utilization. And then if they use that, they can come back to us and request additional funds.
Yeah, so back to that OIG opinion we talked about earlier, there is some language in there that guides all of us to the fact that we have to create a uniform process. Like everything we do has to have a process behind it. We cannot just willy-nilly give one patient a certain amount of money and somebody else another one without some basis. So all of us up here have uniform grant amounts that have been set by fund. For PAF, our copay program, we utilize a mixture of utilization data if it's an existing fund, which I think most of us do. And then for new funds where we don't have utilization data, we have a kind of an algorithm we've created around, I won't get into all of it, but using cost data for the treatment options and cycles that a patient would be potentially using. So I think I also want to address we help a little people in a short amount of time. All of us, every patient that gets approved, their grants for 12 months. So while we might not be taking new applications, we are helping people all year long with the money that they've been awarded. The only reason that would terminate before 12 months in our program is either they use it all, they're capped out, or they don't use it for a period of, in our program, 4 months or greater. And despite a lot of outreach, they say, I don't need it, or they never respond. And then we repurpose the money, as Michelle mentioned, for somebody else. So it does kind of feel like this, it doesn't feel like it is a frenzy when these funds open, because everybody has gotten really used to the fact that they're not open long. But we also have that pesky first come, first serve requirement. So we can't, eke it out over time as much as we'd like to. We actually started our program back in 2004, allocating our grants once every month. So if we got a donation for $1 million, we'd allocate it over 1/12 so that every month we could approve a handful of new people. And that was a nightmare. On the first of every month, no one could take off work. because the phone rang so badly, it'll like zero our phones out. So we learned really quickly that was not a good idea. So when any of us get a donation, we have to release it, and however fast it goes is however fast it goes. But we continue to support those patients throughout the life of their grant.
Yeah, and I will add too, though, there does seem to be maybe some confusion about the, giving the initial grant and then being able to ask for additional funds. Because when we open up a fund, we find sometimes that there are patients, reapplying, and they don't need to reapply at that point. They still have their original grant. So we do find that, when we drill into that, a lot of time they go into jeopardy, what we call jeopardy, and those funds go away from them. We send them the letter, but they didn't realize that they were able to request additional funds, or they were getting help from another foundation. And, there is a little bit of, duplication going on just because they're not understanding, I think, the full process, that they are approved for a full 12 months and that they should come back to us if they need more. That is also a part of, how we would determine, hey, maybe we need to raise the initial grant amount, or maybe the cap amount needs to go up. There's something going on, looking at the trends within that fund to see if something needs to change there.
And I'll just add from HealthWell's perspective, we also look at average utilization. So within a fund, like what the average patient is using, and that's what we actually hold at approval. And then we have internal processes where we can go up and down on that. And again, they're 12-month grants. I remember years ago we were updating our website, and one of the things that we really wanted to get across was that if you have a grant and the fund closes, your grant does not go away.
Right.
And I was like, why would they think the grant goes away? And it's like, because they're so used to it just being pulled in, kind of being pulled around, because they're patients and they're always getting bad news. So really taking some time to explain that it's a 12-month grant, and as that grant is available for the whole 12 months. And if you hit the cap, then we cap out. But I remember having that conversation, and I think some of us were like, why would they think we would pull the rug out from underneath them? But, people unfortunately think that sometimes is going to happen to them as patients. So.
And if I might add, Krista, for those of you in the room that work with patients directly and are connecting them to programs like ours, we need your help. Making sure that they know, that you enrolled them before that package shows up at their house and they're like, what the heck is this? But also kind of help them understand these finer points. We tell them, and then we tell them again in writing, and then it's on our website, but it's hundreds of thousands of patients. And we would really appreciate any, education that you can give to those that you're working with, so they have a little more confidence in the fact the grant is theirs. They get to choose how to use it, the frequency in which, and kind of the rules of the road of how to make sure they don't lose it, and what it can be used for. Because we see some people that don't get that education and don't read what we send, and then their pharmacy uses it all. And then they're like, but I had this bill that I wanted to submit and it's too late. So it's really, anybody that's in their kind of care circle, really important for you to understand it too.
And just one other thing that I wanted to add or to ask is it's still today, I've been with HealthWell from the beginning, and it still today always amazes me the number of calls we get into the call center, and I don't think people appreciate that number. So if you could just share just round numbers.
Round numbers.
Give them an idea of the calls that we get into.
I believe we receive well over 35,000 into our contact center. Some of them are handled through the IVRS, so the integrated voice response system. But I think our agents are handling north of 20,000 a month.
Yeah.
On an average month.
I think the last one was 37,000.
Yeah. January and February are off the hook.
Yeah.
Literally. Yeah. It's crazy. I don't.
Yeah, we're similar. We handle about 500,000 calls a year, roughly.
We get a lot of calls.
Yeah.
We also have the portals. So, again, some patients are coming through the portal, and then the phone as well.
There's another question in the back.
If you receive that many calls, what's the probability they get accepted?
Well, not all calls are for applications.
Correct.
So I think that's important to know. And the probability really is going to depend on the fund that they're applying to. And I'm not trying to dodge your question. It's just the truth. If they're applying for a breast cancer fund, they could be in queue waiting and the fund closes. If it's something, that is less prevalent, more rare disease, then they're much more likely to get enrolled into the program because the funding is going to be available once they get to an agent. Yes.
In first come, first serve approach, how do you all balance requests coming in with the phone with those that are coming in on your portals?
So when it hits our system, it kind of keeps it in track as that first come, first serve. So,
Yeah, ours too.
Yep.
And I think most of us do like what we call an instant decision or kind of an immediate decision. So whether you're on the portal or on the phone, for most people, not everybody, but most people, if we can verify their income and the information we need at that point, then we'll go ahead and let them know that they're approved. They may have to send us some material and follow up, but it kind of holds their place in line.
There's a lot of integration with our portals.
Yeah.
So
It's all one system.
It's all one system. So whether you're on a call and it's coming in that way or it's coming in through a portal, it's all hitting that database at the same time when you hit that submit button. Any other questions?
I don't really need a microphone because I'm loud. If you want it, it's here. I guess you speak to the elephant in the room. I mean, I think we continue to hear a lot about there's not enough funds, there's not enough funds. And of course we all make comments every day. I mean, I think every one of us probably said, well, if we had all the money in the world, we could solve a lot of problems. And so, that's kind of everyone's task. So I guess my question is really directed about on the funding side of things. We've been, doing things a certain way for a long time in this community. And, I guess I would just like to ask the panel, there's so many changes going on. I don't think any of us can keep up with them all. I mean, it just feels like we're just, that old Lucille Ball thing where they're like eating the chocolates on the thing. I feel like that all the time. It's like, oh God, we didn't do that? Okay, let's do that too. And so you should just start eating them because you don't know where else to put them in your pockets and everything else. But I think though that the question remains is still, profitability continues to go up and up and up. R&D has always been a driver between cost requirements for manufacturers. So they continue to put a lot of money into R&D. If you look at the pipeline of the drugs that are coming out, all the biosimilars and everything else, arguably there's a lot more that is kind of in the phase 2, phase 3 stages where a lot of that investment has been made. And arguably with sustainability most likely becoming a little bit more stable for the foreseeable years, it seems to me in a very large, I know I'm way overstepping all of my bounds here by assuming, but it seems to me that I used to be a financial planner for 15 years, so I think about this at a macro level, is that there is so much more money coming into the system. And so while there is a sense of lack, if you will, within the fundraising side, as a panel, do you feel like that, how much do you feel like our view of the need versus the demand versus the supply plays into the willingness for there to be additional funding to come? And is that willingness going to get better over time? Do we think it's going to get better? Or do we think we're going to continue to see the same things where it's just pressure, everybody's got to do more with less and just continue to get squeezed? Because arguably on the financial side, when I talk to Wall Street, everybody there says there's more products, there's more money, there's bigger reimbursements. Granted, there's pressures, but there's more coming. It's actually not a scarcity problem. It's actually an abundance problem. So I'd like to know, what are we doing about that? And how much of that is our mindset as we fundraise compared to the mindset of the industry? Sorry.
That's a question.
That's a question.
A really good one. From my perspective, I've been involved in fundraising for this for a long time too. And I'm not afraid to ask for hundreds of millions of dollars because I agree with you. I do feel like the manufacturers can, in many instances, support the entire need if that's a priority of theirs. I do recognize that there's, in most disease states, not all, but most, there's multiple manufacturers that all need to do their part, which is not always consistent. And there are investments they make in their own programs, which cost money. And they have shareholders that they're accountable to. So all of that is a really messy, kind of picture on their side of the equation. From our viewpoint, I think we have a pretty good handle on what the need is across our organizations because we have the data. We have the frontline knowledge of the patients that are calling us and not getting help and those that are. And if you see the unfortunate thing that has happened since COVID and the inflationary environment we're in, there are people that would never have needed our help in the past that do now. So the population has kind of organically gotten bigger. You also still have the aging population continuing to age, and it's not a small one. So just the sheer number of people that need help and would be eligible under our current guidelines today is different than it was 3-5 years ago. So, I think from our viewpoint, at least at PAF, we're given some really hard thought to our mission has always been to serve the most underserved. And I am not sitting here saying somebody at 5, 6, 700% of FPL or beyond don't need that help because they often do. But what responsibility do we have as stewards of limited resources? Because I believe they will always be limited. There's always going to be a budget in these companies that make donations to us, and that's going to be that. It may change over time, but there's going to be a fixed amount that they're willing to put into this kind of help. So how do we steward that money and get it to the people that need it the most? Is it lower in the FPL? I don't know. Is it, targeting some of the money in geographic places that are known to be more vulnerable? Maybe that's an option. Like there's some other things that, I think we're all called on to kind of consider. If we can't eat the whole elephant, how do we take as big a bite as we can?
I don't have much to add to that.
I don't have much to add to
Fran
that
did a good job. Yeah. There's actually 2 right there, so.
Hi, I'm Robert Clark. On that particular question, in my view, it's what's going to go on a Capitol Hill that's going to be a limitation on how much funding and what donors do in the industry because although it's been quiet, we had the Warren White House Commission that looked at the entire industry and some of the abuses that were going on insofar as interactions between CPAPs and donors and the settlements and the corporate integrity agreements. And the commission came out with a number of recommendations that could change the whole complexion of the industry. So in my view, what happens with the legislatures will be have a great impact on what's going to happen in that regard.
I was just going to briefly share an industry perspective on that too. I know you mentioned like R&D as being a really expensive area that pharma spends money in, and of course they need to, right? Because we're always expanding our pipeline. But I would just share also that the commercial side of the business, the brand teams and things, right, who are promoting their products and handling the marketing in that part of the business, are generally not and can't be the ones who are making the decisions about charitable spending. So there is quite a distinct firewall, at least in my organization, that I manage like the patient support programs, like the hub side of the business. We're not allowed to influence where the donations go. The commercial side of the business isn't allowed to influence where the donations go. It's all handled by like the foundation part of the business. So I do think some of that is like the left arm and the right arm, not that they're not speaking, but like they can't actually, because we do have to have that kind of divisiveness.
Great. Well, I think we're basically at time. Thank you so much, everyone. I think we have a quick break, and then we're back in here at 10:15 for another panel. Great. Thank you.